Everyone, sorry about the technical problem. We start promptly now. Our this week's teaching, Shwan is presenting on nice topic of non-union, very important FRCS question. So you're all invited to listen, and please put your questions in the chat option. This will be followed by hot seat session. So please start expressing your interest from now. Send me messages. Okay, over to you, Shwan.
Hello, everyone. Thank you for joining us today. I want to thank FRCS and our Ortho mentor groups for continuing to make this a possibility. I'm just going to share the screen. We've got a PowerPoint presentation coming up. Here we go. So I presume everyone can see. I'll go to present screen. So today's topic is about how to approach non-union in the exam. This is not a complete answer. This is not a tutorial on non-unions and all possibilities of non-unions. This is all about how to approach. I'd like to state that, first of all, everything I say in this is my opinion, and it's not affiliated to any group, and this presentation is not affiliated to any group apart from our FRCS mentor group. The first thing to say to you is this is the picture you will receive in the exam or something accordingly. And what do you do? Doctor, what do you think? First of all, don't panic. Don't start saying who messed this up, and don't start crying and breaking down about this. It's an easy question. You just need the system to get through to it. So first of all, you need to say, stay calm. Describe what you see. So for example, in this X-ray, in this radiograph, I'll say lateral radiograph of distal femur with a short retrograde intramedullary nail inserted for a distal femoral fracture on what looks like, in this view, a well-fixed total prosthesis. Concerning me here is the hypertrophic, ultratrophic, atrophic non-union. You should all know the definitions of either and to be able to describe what you're seeing straight away. Now you have time. You've got your opening sentence, you're relaxed, you're getting ready to talk about your pathway. But don't forget to ask for overviews and full length. You need to know the full story of this patient before you jump in and say, well, that was a very short nail, so the reason why this failed was because of the surgeon putting in the wrong nail or something like that. Naturally, you're not going to see position A, but I just shown you all the possibilities that you could have that would give you a reason why you would think a suboptimal fixation might have occurred, okay? But always remember, you're not sitting in the radiology exam. What you see is the opening question in your exam. It doesn't carry any marks. It's just to get you comfortable and get you onto the substance and get to the substance. And please, you all live in glass houses. Don't criticize the previous surgeon. You don't know the circumstances of the reason why it happened. Was this a bailout option? Was there problems associated with the patient? Was there multiple injuries? You don't know the full story, so don't criticize the surgeon in the middle of the exam, okay? So the question will be, what do you think, or what would you do, or what is a non-union? So I would define a non-union as a fracture which has passed the expected time to heal and is showing no signs of progression. Non-unions have multiple causes and often may be multifactorial, and my management will be guided according to the causes, which I would divide into infection, local factors, systemic factors, and mechanics. Simple get out of jail sentences, get you into the flow of the discussion, memorize them and use them, okay? So infection, non-union should be considered any non-union should be considered infected until proven otherwise. What will help you decide is the history, the chronology of events, was there presence of sinus on the examination, and the presence of scar, primary versus secondary. Don't get into the habit of asking the examiner the question, is there a sinus, is there a scar? Say, I presume there is no, the scar is by primary intention with no evidence of any sinus, and history and examination has low suspicion for infection. However, I would like to outrule infection. Blood markers, cultures. When you do mention cultures, do talk about tissue samples, because that is being shown to be the most accurate, as opposed to simple aspirating the sinus or anything like that. Take bone or soft tissue samples next to the bone. Radionuclide scanning, labeled leukocyte scanning, and MRI are all options. Their sensitivity and specificity vary between different papers. The most sensitive is MRI scan, however, it can be a false positive, and the most sensitive and specific is labeled leukocyte scans. However, the problem associated with them is that they are very good at picking up acute infection, but in chronic low grumbling infections, they're very poor. And then I've just left a table there for you guys to pursue later on about the Cerny and Nader classification system, which divides anatomic type with physiological class, and it helps you develop a management plan for these patients if this is where the question is going. Moving on to local, remember, you don't have a lot of time to be talking about every part of this, so just make sure you get your headings in first so that the examiners know where you're going. Local includes index injury, fracture personality, energy, stability, vascularity, and location of the fracture within the bone. So if it's tibial diaphyseal, it's a higher risk of non-union versus, for example, a metaphyseal tibia. Open fracture, compartment syndrome, and soft tissue stripping, either preoperative or time to surgery, are big factors in all of this. On the right, you'll see some papers. You can look at these later on when the video's on YouTube. The first group of papers are all about the Costello-Anderson classification system and the risk associated with non-union. Blair et al. Showed that compartment syndrome is a good predictor for non-union as well. And Tuchern's classification system for soft tissue injuries without an open fracture, which often indicates a severe vascular injury to the soft tissues. Surgical techniques is the second part of the local. Tissue handling, tourniquet time, wound coverage, all of these things matter. Reamers and their use without saline or fluid to decrease the risk of heat osteonecrosis. The inappropriate use of distractors and external fixators, which potentially need to be aware can strip tissue if you over-distract. And your approach can decide if you're going to damage the soft tissues around the bone as well. My philosophy on any fracture is a fracture is a soft tissue injury with a bone in it. Literally remember to look after the soft tissues, because revascularization of ischemic bone fragments is all about the soft tissues. It all comes from the soft tissues. If you can preserve soft tissues, you're likely to have preserved bone. Your approach as well, your appropriate application of fixation devices and cast at the time of surgery, okay? Systemic issues includes a patient comorbidities such as diabetes, COPD, peripheral vascular disease, steroid use, immunosuppressants, endocrinopathies with thyroid and parathyroid problems, and vitamin D and vitamin K. Remember, vitamin D on its own is not enough to ensure a patient, normal vitamin D on its own is not enough. Patient needs to have vitamin K to help them metabolize their vitamin D. Patients' social factors such as smoking, alcohol, other drugs, marijuana use has been shown to stop bone dead, and patients' compliance issues. Patient has a history of psychiatric illness or not able to comply with non-weight-bearing plan that you had developed looking at an x-ray, or patients' personal circumstances doesn't allow them to come frequently enough, for example, to keep an eye on the wound while you're treating with an external fixator. And then mechanics. So in the mechanics part, I could spend a long time explaining to you all about the biomechanics, but we'll do another presentation about biomechanics and how to establish healing and so on. But remember, when you're talking about mechanics for non-union, you need to establish 3 questions. What was the principle attempted? Was an appropriate principle for the fracture configuration? And was it achieved? So, for example, in anatomical reduction and absolute stability, where you want primary healing, these are usually for intra-articular fractures, simple 2-part diaphyseal fractures. While relative stability, which uses bridging principles, you need relative secondary healing. And again, you need to establish what is the most appropriate fixation principle that you want for this fracture, and then what tools would you use to do this. And if they have used the same tools, was their initial plan achieved? If not, where was the problem? If you establish all of this, you can probably establish the issue behind the problem. And then we get to management. So now at this point you have said there are local factors, surgical factors, and mechanical factors. You've already said I've outruled infection. Now you're going to get on to the management. Now, unfortunately, this is not something I can answer to you straight away, and we'll get plenty of opportunities later on in the hot seats to discuss management of the different variations of presentation. But I would use keywords. This is a difficult problem. It recognizes that you have experience with this, or recognize that this is not an easy problem you're going to use. Assess, cause, and address the causes. That's the most important part in developing your management plan. So and you notice I put S in plural because they could tell you this patient is a diabetic with this X-ray, or they could tell you that this patient is a heavy drinker and so on. So you need to establish how you're going to address individual causes, both systemic, local, and patient factors, okay? Describe, I would definitely use terms like MDT approach. I would consult with my bone infection unit, discuss with my reconstruction surgeon, discuss with the medical team that are looking after this patient's X, Y, and Z. Discuss the social issues, involve social workers and or allied health professionals in your development of your management plan. And don't hesitate to say you would compare with colleagues who have more experience. However, that prompts the next question, doctor, what are you going to do? Or what will they say they will do? So you still need to develop your plan accordingly. But giving an overall approach to this and moving quickly through this will allow you to get on to discussing where the meat of the question is. For example, is this question all about infection? Is it about mechanics? Is it about primary versus secondary healing? Safely managing a complex case? It could be about biomaterial, bone grafting, and I've put in lots of letters in there to say it could be anything. The question can go in any direction they wish it to go, but take your cue from the examiner and don't get yourself into difficulty by going into fine details. Trust me, stay in the basics, keep it simple. So in conclusion, don't panic, keep it simple, develop your structure and answer accordingly. You can tweak this answer to pretty much any scenario. Examples would be, tell me the factors that lead to non-union. What are the principles of healing? How can you decrease risk of non-union? What factors lead to infection and trauma? Why does this not heal? Literally every topic comes up in those type of questions again and again. Understanding the biomechanics, we'll come to that hopefully next week or the week after. I'll have another presentation for you guys explaining how we can deal with the principles of too much rigidity or too little rigidity and so on. Okay, is there any questions?
No, I think there's not been any questions. I think it was very clear presentation, Shwan, as ever. And I urge everyone to review this presentation again when the recording is sent, because it contains, in my opinion, everything you need to know to answer this question perfectly in your Viva station. I like the definition that Shwan gave for non-union. I've seen some situations when examiners insist on the candidate a little bit more on what happened. Can you give me a timeline? Is it 3 months? Is it 4 months? And I think I would insist on not giving a timeline. And it is all combination of radiological and clinical factors, or clinical signs. So insist on those. I would look for radiological and clinical signs of non-union. But there is the FDA definition. The FDA has defined non-union as absence of progressive bone union of a long bone only. They only define that for long bone for a period of 4 to 6 months, after 4 to 6 months. So even if you're stuck and you have to give a number to examiner, you could mention that FDA number, but
so, for example, the problem associated with non-union is that you have to be very careful if an examiner is pressing you for a month. I agree with Firas, how many months is a non-union. It depends on your fracture type, depends on what bone is affected and which parts of the long bone. A tibia you do expect to take longer than, for example, a mid-shaft femur. And then the consequences of a non-union are far greater in a patient, for example, with a subtrochanteric femur fracture where you've nailed, where you can have a race between the bone healing and the metal wear failing, okay? So make those issues clear to the examiner that this is, if you're not seeing progress about a certain time, you're worried about failure of metal wear before fracture healing, okay?
Great. And we have a question, Shwan, about the role of bone marrow injection. Are you aware of anything?
So there is quite a number of papers involved in all of this. So the problem is you can quote as many papers as you like, and that's fine. Go right ahead. But what you'll find is that you will know your paper well and discuss the use of different bone marrow or bone morphogenic protein or bone graft. Just be aware, the only thing not to get yourself trapped into is don't put good, healthy bone, even if it's dead, into infected bone. Be careful, because you're now going to the 8th question and you've forgotten this patient is infected and you start talking about bone grafting and so on, okay? There is plenty of papers. I don't need to give you quotes. There's lots of them, and if you know a paper, feel free to quote it. But I wouldn't give you one offhand.
Sure. And another question about the use of exogen, and I think in the exam, try not to suggest this slightly controversial issue. But if the examiner asks you, and I think exogen. It is in the NICE guidelines of management of non-union, not the actual device, but I think
so there's a nice review on exogen and union. If you want to read it, use it, but if you're going to bring it up, you need to know that NICE guidance very well. However, I would say to you, if you're going to talk about an exogen ultrasound, then you need to know why you're using this. Again, be very careful, stick to the principles of your management. You're a surgeon. Understand that there are infection, local factors, systemic factors, surgical and mechanical factors. Address those issues. Yeah. Don't use your exogen as your bailout thing for every scenario, because the question is not about exogen. The question is going to be about do you understand what causes non-union and how to deal with it?
Yeah, I think if you know the NICE guidelines, you could mention them at the end after you've mentioned everything Shwan said. You could mention them, and then you'll be quoting literature, because there has NICE guidelines for non-union after 9 months of long bones only. So unless you know all these specific details, as after 9 months. And after for long bones only, then otherwise don't mention it. Okay. So if you're not very sure about it, don't mention it. But yeah, it has a role in the management. Hussam, would you like to say anything? We have Hussam here, one of our mentors. He's kindly joined us. Would you like?
Thank you, Faraz. I think Shwan covered well from while he was running the slides. The only thing, again, as always, Shwan is saying and everybody's saying, keep it simple. It's about that you know what the non-union means, what should come to your mind. It is like in the revision of the hip or osteolysis or pain in the hip, it is infection. It is infection. So everybody, he wants you to think infection first, and then go on after that. And as long as you are keeping with the principles and going step by step with the timing, with the following up, maybe CT if you are not sure about all these, what we are doing daily in our practice. But don't go into the ultrasound and everything, because he will catch you over there. He will catch you over there. So just keep it simple. And 5 minutes really, really short time.
The presentation I just did took more than 5 minutes, and that's just getting that information across to you guys. You need to be able to get that information across to the examiners as well in a fluid and simple way.
Exactly. I mean, that's the whole idea. It's a short, crisp presentation, tells candidate everything they need to know. You have only 5 minutes in the exam, so it's not about not about talking a lot, having a massive amount of knowledge. It's about presenting your answer specifically. So in the exam situation, non-union, always think of infection and mechanical, and it depends on where station you are sitting in. If you're sitting in a basic sciences station, it could be leading you towards mechanical factors, and the examiners want to discuss biomechanics of fracture fixation and stuff like this. So if you felt it's going that way, if you've seen a plate failed, for example, or a nail has failed, please straight away get into that discussion of biomechanics. Don't waste a lot of time on other issues. So
exactly, for us, take your cue from the examiner, because if the examiner says there's no sign of infection or all results are negative for infection, don't start beating the examiner with, I'm going to look for infection, I'm going to look for infection. Yeah. He's told you there's no infection. Yeah. The topic is somewhere else. The marking is somewhere else.
Yeah, we see that all the time. Yeah, if examiner, if you tell the examiner, I want to rule out infection, and that's it, the examiner will tell you there are no signs of infection. Move on. Don't keep saying, oh, I want to know his CRP. What's his CRP? What's his...
Yeah. Exactly.
We got a question like on the fracture of the femur, and it has been treated with nail, and it failed. And then all the discussion was about, okay, why it is failed. So I talked about first rule out the infection, then it's about the short segment, and it's about the working length, and also the type of the host and all these things. And then because it was actually protruding to the knee, and then what's the next step and what we're going to do. And then we talked about, okay, plating first. And I talked about how the plate, and again, about the spreading of the screws. And so the stresses would be distributed. And then after this heals, I will go for a total knee. So it was about everything, thinking about the patient from the beginning until even the next step, what you're going to do to get the patient to the best status to treat him or treat her at that time. Yeah.
I'm not sure where was the question again?
It is Nadeem, from Nadeem. Is the exogen, after the exogen one,
how should I didn't get that question. So could you repeat the question again, just so I can understand it?
How should you find out necrotic segment in infected non-union?
So necrotic segment is based on the definitions of when you're looking at the X-ray. A sequestered piece of bone is essentially a necrotic segment. Any part which has no vascularity. And what is the definition of vascularity to a bone? A bone which is not in continuation with the other bone, and or has no soft tissue connection either. Any bone, so if you're doing a debridement as well, any bone which is not bleeding is considered a necrotic segment in an infection. Okay.
That's great. Thank you, Shwan. I think most people are very keen to get on with the hot seat session, and I think we answer all the questions. It's a great presentation. We had 36 participants, and which is great. Thanks to everyone who attended. I'll end this session now, and I will send another invitation in 2 minutes only for the hot seat session. So far, I have 3 candidates who expressed interest, and we'll go in order. We have